I have to say that I'm just flabbergasted at the turnout this evening. And I think one of the things that's going to keep me awake at night is trying to figure out what is it about the people of Sudbury that makes them so interested in death. I've been long anticipating this evening being on a podium with the likes of Brian Goldman. Is quite the honor. He is, of course, one of Canada's most recognized and trusted physicians. And, appearing before him feels like, well, it's a difficult place to be. And let me kind of illustrate that by asking how many people here remember when the Beatles were on the Ed Sullivan Show? Does anybody here remember? Okay. So my next question is, does anyone remember the act that came either before or after the Beatles? Anyone? I think you see my point. This is the conundrum that I find myself in. I think it may have been Popo Gigio. Somehow that kind of rings true. Yes?
Wayne and Schuster.
Oh, Wayne and Schuster, there you go. Okay, so I'm here to tell you a little bit about palliative care and hopefully to make you comfortable with some of the issues. And again, I think we're deeply indebted to Lauren for sharing her particular story and the story of how she and her husband confronted this final journey. I have to say, as a palliative care physician and as an academic and speaker, I'm very used to being put on the podium at the very end of the evening, at the very end of the schedule, and most people are extremely tired, slightly closer to death than they were at the beginning of the evening. So I decided that I would begin tonight's presentation with a short video, and the video is meant to capture in very short order everything that I think you need to remember and take away from my talk this evening. So without further ado, here we go. Well, that concludes my talk. Are there any questions? So why begin with this shocking presentation? Well, first of all, it's to make sure that you're all awake. You're all on the edge of your seats. But as well, there's a very serious message, and that is, if you have a pulse, one day you won't. And that is just a fact of life. All of us enter into this world in a particular way, and all of us are destined to exit this world in a particular way. What happens in between, of course, has extreme variability. Some of us are in flight longer than others. Some of us encounter more turbulence than others. But life begins and life ends. And as Lauren very astutely told us, if we don't anticipate that, if we don't start to plan for that, if we don't know our options, of course, we're not going to know what options are available to us. It's hard to give a talk on palliative care without invoking the name of Dame Cicely Saunders. And some of you may know that Dame Saunders was a remarkable woman who actually was the founder of the modern hospice movement. When you look at Dame Saunders' background, it begins to give you a flavor of what palliative care is about, because she began as a social worker, and then she trained as a nurse. And eventually she decided that she would train as a physician. And her mission in life was to make sure that she had all of the skills that were necessary in order to help people at the end of life have comprehensive care, which meant that she wanted to be competent in areas of pain and symptom management. But she also knew very much that end-of-life care was about good psychological support, broaching spiritual issues, dealing with existential issues. So palliative care as Dame Saunders conceived it to be, is about all of those things. Palliative care is not about a place, as was already referred to earlier. It is about an approach. It's about a philosophy of care that takes into account all of the things that go into making up human beings that are important for us during the course of our life up until the very end of life. Now, I have to say that when I was a wee bit younger and had maybe slightly more hair or slightly less gray hair, I had the opportunity of meeting Dame Saunders at St. Christopher's Hospice. As I say, she was a remarkable woman, but she also had this reputation as not suffering fools gladly. And I began to think, oh my goodness, I'm going to be meeting Dame Saunders, who you have to understand was to palliative care what Mick Jagger is to rock and roll. I mean, this was a very important, influential woman in the history of medicine and certainly in the story of palliative care. So I flew to London, I flew to St. Christopher's Hospice and grew increasingly anxious about what question it was that Dame Saunders would ask me about some of the work and some of the research that I had been doing. Now, you'll notice that the meeting, at least at the outset, must have been going relatively well because we seemed to look happy. And you're probably wondering, well, what question did Dame Saunders ask you when you first met her? What I have to say is the only question she asked me was, would you care for a sherry? And this was her liquor cabinet right here. And so the two of us looked glossy-eyed at 11 o'clock in the morning because when Dame Saunders says, would you care for a sherry, there is only one answer. And the answer was, of course, yes. Now, my background, my training is in the area of psychiatry, and I've gone on from that training to really enter the whole area of palliative care and palliative care research. And you might be wondering, as a psychiatrist, how does one do research on these areas that are so deeply human and in some ways may seem so ephemeral? So I decided I would show you one piece of data, and by the way, anytime that you see a slide up there that has squiggles or numbers, don't worry about interpreting them. They're meant to be a cue to me to remind you of what you need to know. This shows you some data on a woman with end-stage colorectal cancer. This was a woman who was about 80 years old. And when she came into the hospice, what you'll notice, or what I'm telling you this slide depicts, is that her will to live was poor. Immediately improved when she entered into a palliative care facility, and then towards the end of her life, will to live became a little bit more erratically reported. Now, in this next slide, what I'm showing you, and I apologize if it's hard to see, but you see now two lines, one being the line that looks at this patient's will to live, and the other line that superimposes her experience of pain. And if we were to use a dancing metaphor, this would be a tango. What you see happening here is in this patient, when her pain becomes well controlled, something as spiritually based as her will to live, her wish to go on living, actually improves. Or it could be that once she's no longer worried about the many things that were happening at home and she has comprehensive palliative care, that her perceptions of pain are altered in a way that she's far more comfortable. And again, I would say that if there is something that is emblematic of palliative care, when I look at this particular slide, I think about what palliative care is about. Because, of course, palliative care is a discipline of medicine which attempts to provide comfort for people with life-threatening or life-limiting conditions. Now, when we studied will to live, what we eventually found ourselves looking at was, why might people lose their wish to go on living? Approaching end of life is not necessarily an easy journey, as we've heard. And for some people, there seems to be a loss of will to live, whereas for others, there seems to be this wish to savor whatever moments life continues to provide until the end of time. Well, when we began to study this notion of dignity, and we found that dignity oftentimes was the language that people used when they talked about end of life and trying to have the best quality of life until the very end, we found that Amongst people who lost their sense of dignity, and all of the studies that I have done have been in patients who've been within about 6 months of near the end of life. They've all been in a palliative care facility, either in a hospital or being looked after in the community. And palliative care, as we said, is not about a place, but about an approach. And it's an approach that very much supports people being looked after in a place that they choose. And the vast majority of people, as Lauren and her husband chose, would be to die at home if possible. And the likelihood is that if one does good planning and one knows one's options, then the likelihood of dying at home is exponentially increased. Now, when we've looked at patients and asked them about this notion of dignity and what it would take to support their dignity, we found that in people who were beginning to feel that their dignity was being lost, that along with that, there was a sense that of a great deal of psychological suffering. You know, a wish to die, a loss of will to live, things like depression and hopelessness and anxiety. These are really difficult psychological symptoms that these patients who lost their sense of dignity might also feel. We also found that experiencing pain or experiencing difficult physical symptomatology can be an assault to sense of dignity. So if we in palliative care are attempting to support dignity, then we need to become experts at how we can manage all of these things that might assault your sense of dignity. These things we've called, like bathing and dressing and toileting, these are what we've called in our particular writings the intimate dependencies. Sometimes when I'm talking with medical students or residents or medical trainees, and we talk about empathy, I remind them that if you go into any hospital or into any palliative care facility, these things, bathing, dressing, toileting issues, this is such a common thing that we become completely blind to it. It's just not on our radar. And so what I remind all healthcare providers is to become empathic. To really understand empathy, you need to try and personalize what these things are about. Even though every day on a busy ward, these may be happening everywhere, the truth is, if you or someone you love is reliant on somebody else for these intimate dependencies, these are the things that really can begin to assault your sense of personhood. And so we need to be mindful of that, and we need to be careful around how we manage these issues. Now, this particular slide makes what I think is one of the most important insights that we discovered during the course of this study on dignity. And you'll notice it looks like a reflection in the eye of a particular individual. And in that reflection, we're seeing an elderly gentleman, looks to me as if he's in a study, perhaps surrounded by some books. And what we found in the study that we did on dignity amongst a group of over 200 patients nearing end of life, the thing that was most predictive, the thing that determined whether or not their dignity was going to be held intact or broken or fractured, as we called it, is how they perceived others to see them. It's a bit of a mouthful, but perhaps worth repeating. How they perceived others to see them. Well, what do we mean by that? Well, if you look into someone's eye and you don't see your own reflection, and somehow you feel as if you vanished, you're not there, you don't matter. If you look in the eye of your healthcare provider and all you see, is the blood work or the lump that was discovered, then you feel that you have been reduced to your illness. But if you look in the eye, and again, I'm using this metaphorically, but this is very much what the data showed us. If you look in the eye of your healthcare provider and you can see yourself, all of who you are as a human being, as an individual, then your dignity is most likely to be upheld. Now, I'll tell you, as a researcher, when I discovered this in the data, for me, it was really an epiphany. It was really a wonderful insight. And it took me back to a memory when I had been a fellow at Memorial Sloan Kettering, which is a cancer center in New York City. I'd been assigned to the neuro-oncology service, and I was looking after a young man who had a primary brain tumor. I went into his room, and this was, I believe, the last time that I was to see him. And I remember I went into his room, and at the time, he was this emaciated, wasting away skeletal remains of this young, healthy man that he'd once been. On his bedside table, there was a photograph of this same young man, and he had been a bodybuilder. And so there's this incredible juxtaposition of these two images, this emaciated young man who was very near death, and this photograph of this kind of Adonis-like looking male in this little bathing suit with this incredible Hulk kind of pose. And I remember at the time being struck by the juxtaposition and I suppose the tragedy of what was happening. But it was years later when I looked at this data that I came to realize what he was telling me. And what he was saying is, this is how I want to be seen. This is how I want to be appreciated. You know, there's a great irony in medicine. We spend all of our professional lives learning to look after patients. Well, guess what? Nobody wants to be a patient. Nobody likes being seen just as another patient, because being a patient means being patient, having to set aside your own schedule, sometimes setting aside your own needs, to conform to the things that the healthcare system would demand of you in order to receive care. And the one thing that we don't want to lose is sense of self, sense of personhood. So as we continue down this research path, and again, this is not meant to be a test of visual acuity, although if anybody can read the bottom line, I think you should go to your optometrist and tell them that he or she has done an extraordinary job with your visual correction. So when we continue down this path of saying, understanding dignity seems to be an important issue or important key in understanding how we can do better end-of-life care. And in fact, it was a genre, if you like, of end-of-life care that I began to call dignity-conserving care. And this particular article in the Journal of the American Medical Association described it as a new model for palliative care. Now, when we look at the particular components of what I've called dignity-conserving care, and again, don't worry about the details, leave that to me, what you can see is this. According to a large group of dying patients, there are a multitude of things that might affect your dignity at the end of life. And we're all wired differently, aren't we? So for some people, things that the illness itself might inflict or might impose on you. So making sure, for example, that you have good pain control. Being left in pain is an undignified way to go. It is an undignified dying, and something that every patient should be demanding of. More so, managing a whole spectrum of symptoms. In fact, way down here in this wee small print, it talks about uncertainty and death anxiety. For some people, not knowing what to predict, not knowing how things might unfold. These are things that can cause patients great anxiety. And so when we heard Lauren talk about how important it was when that hospice nurse came in, it was important because you had somebody sitting down with you who could talk about the issues, who could talk about the elephant in the room, who could say, these are the things that you can expect. Because sometimes what really can drive people to distraction is anticipating things that might happen, not necessarily that will happen, but that might happen, that can cause them great anxiety. And one of the things that we can do in palliative care is to allay those fears by saying, we will not allow that to happen to you. This other area of the model, something we call dignity-conserving repertoire, it's fancy language that just means that personhood is important. So we need to be able to deliver the message in a variety of ways, subtle and not so subtle, that who you are is important. To ask you about personhood, to ask you about important roles and values and what is meaningful and what is important, and what about your spirituality or religiosity. All of these things are part and parcel of good, comprehensive, palliative, dignity-conserving care. And finally, this social dignity inventory simply means that we discover that there are things that happened around the patient, in the patient's environment, that can have an effect on dignity. One of those things, for example, is something that we call care tenor, the tone of care. And isn't it the truth that sometimes people can do something, they can take a particular action, and even if the action is correct, if the tone is wrong, it can feel like an assault, it can feel like an affront. So even though the diagnosis may have been accurate, even though the prescription may have been accurate, if it's done in a way that makes you feel like you were just another patient, like you were somehow processed, like when you looked at the reflection in that eye, you didn't see self, you may not have seen anything at all, that can be undermining of your dignity. And when I've spoken in healthcare centers around the world and talked about this notion of care tenor, I've had presidents and CEOs and chief medical officers in healthcare facilities worldwide saying, that's what patients complain about. That's the reason we get into trouble. In fact, there was an article that came out a number of years ago in the Journal of the American Medical Association by a woman named Robin Tamblyn. And what she found is that the most likely reason that physicians are likely to be sued, likely to be called before their regulatory body, is because of this care tone issue, a breakdown in communication. So medical competencies and technical prowess are absolutely critical. They're absolutely important. But oftentimes, those aren't the things we get wrong. We forget about tone. And when you forget about tone, patients suffer. So with this insight that dignity is an important pathway that leads to good and comprehensive palliative care, what are some of the things we've learned? What are some of the skills that we can pass along to healthcare providers, and maybe even some of the insights that we can pass along to patients and family members? Well, one thing that we've developed in our work is something that we call the ABCDs of dignity-conserving care. Now, in healthcare, and Brian here is a professional in so many ways, a professional educator and broadcaster, and an emergency medical physician for whom the ABCs are clearing an airway, breathing, circulation, making sure that if somebody has an acute event, that their heart has stopped and they're not breathing, all healthcare providers ought to know the ABCs of critical care. But when it comes to the humanities of care, most of us, we're not necessarily taught that in a particularly formatted way, and most of us are just told, trust your gut. And we know by the number of times there are complaints in the newspapers that not all healthcare providers have a talented gut. It's just the facts. And if Brian here, God forbid, were to start to choke to death, and I were to go up to him and just give him professional empathy as he took his final breath, to say, does this remind you of, some early childhood experience as he asphyxiated and died? Sorry, Brian. You would say, that is the most ridiculous thing I've ever seen. And I would say, but I'm a psychiatrist. I gave him professional empathy. And you would say, but no, as a healthcare provider, you should know the ABCs of critical care. Well, why can't there be the equivalent ABCDs of the humanities of care? And I would suggest that there ought to be. And what would those look like? Well, first off, it would be that the attitude of the healthcare provider is important. Now, know this from the data that I've shown you earlier, or if the reflection that they're looking at in the eye of the healthcare provider needs to be reflective of that whole person, then your attitude as a healthcare provider makes a difference. It makes a profound difference. Now, I don't want to sound as if I'm pontificating, and as a researcher, I can show you that attitude is of vital importance to patients near the end of life. So here's another study, and again, ignore the numbers because they're too small for you, but fortunately for you, they're large enough for me. This is a group of over 200 patients near the end of life, and we said to you, what matters? What is important to you? What would support your sense of dignity, or what would be an assault on your sense of dignity? Well, thinking how life might end, or even things like distressing symptoms, about half of them say yes, that would be an important issue. That could be, in fact, be an issue that, might affect my sense of dignity. no longer feeling like who you were. Nearly 74%. And in Lauren's story, she shared with us ways in which her husband may have felt that the things that gave life value, the things that were cherished, began to be withdrawn. And the psychology of illness really is the psychology of loss. Illness takes away things. When we're not very sick, it just takes away convenience, takes away time. But as we become more ill, it can take away that sense of, am I still me? It's a profound question. And again, what we found is that nearly 75% of patients said no longer feeling like who I was is an important issue. The things that were most highly ascribed was feeling like a burden to others, so feeling like I no longer serve a sense of purpose and not feeling respected. Well, where does respect come from? In a healthcare context, it's something that we can offer to patients or we can withhold it from patients. So this whole notion of respecting our patients, providing them with affirmation, along with good symptom management, along with spiritual support and psychological support, these all go into providing comprehensive quality palliative care. Now, sometimes in medicine, we make the mistake that to see is to believe, and we think that we get it. We look at a situation, we evaluate it, and we think on the basis of what we see that we understand another person's reality. And I think Brian will tell you, and I can certainly tell you from many years' experience in working in clinical medicine, sometimes our perceptions, the perceptions of the healthcare provider, aren't necessarily the perceptions of where somebody actually lives. So I think we need to approach every patient and every family with a deep sense of humility. We don't know the culture of your family. We don't know your values. We don't necessarily know what's important to you. And so finding out about good palliative care is not simply about kind of the routine questions are, how is your pain and when was your last bowel movement? Important, but what matters to you? What are your priorities? What are your goals of care? These are critical issues if we're going to do a good job of comprehensive palliative care. The B is for behavior, and some of these things are pretty straightforward. Do we stand at a bedside, or do we sit? Do we meet someone's gaze, or do we avert someone's gaze? These are all ways that we can convey a message to our patient. Do you matter, or are you just another patient? Simple things like asking permission to do an exam. It is your body. Letting you know that the patient is in control can have a profound influence on the experience of receiving health care. And oftentimes there's this rationalization that if there is no opportunity for cure, then maybe I don't need to be spending my time as a clinician at the bedside. The truth is, nothing could be further from the truth. Our presence at the bedside is of profound importance because it gives us an opportunity to know patients, to know what they're frightened of, to know what they are dealing with so we can help them to orchestrate an end that is going to be the very best for them possible. Now, the C is for compassion, and we could have an entire evening dedicated to talking about issues of compassion. What I've said to my healthcare colleagues is to understand compassion, you need to understand your own vulnerability. If you can't understand that there's very little that separates you, the healthcare provider, from your patient, then talking about empathy is always going to feel something that's kind of distant and intellectualized. The truth is, all of us are mortal. All of us are vulnerable. Now, there are different ways of invoking compassion, and one of the ways that is perhaps oftentimes used is this whole issue of illness narrative. People often write about their experiences of being in healthcare. It's important for us to tell the stories of what it's like to encounter care. It's important for healthcare providers to understand that, so we understand the human side of medicine, but it's important for patients to tell their stories as well, because in telling their stories, they're reminding us that they're not just a patient. They are a human being, they're a whole person. Now, I don't tend to like much of illness narrative because sometimes it can be maudlin and depressing. On the other hand, I'd like to read you just a short snippet from a piece of illness narrative that I very much admire. This was a man called Anatole Broyard. Anatole Broyard was the former editor of the New York Times Books Review section. He was a brilliant writer. He had prostate cancer. Eventually, he died as a result of his prostate cancer. But he writes with tremendous flair and humor and reminds us, in the context of experience an illness, of the things that still matter to them. So this is from Anatole Broyard. The doctor warned me that, like radiation, hormonal manipulations would kill my libido. I find this hard to believe, especially in the case of a writer for whom sexuality is inseparable from consciousness. After 3 months of treatment, this has not yet happened, and I persist in believing that it won't. I've been manipulating my sexual hormones all my life, and I don't see how a drug can deprive me of this privilege. My libido is launched not only in my prostate, but in my imagination, my memory, my conception of myself, my appreciation of women and of life itself. It belongs as much to my identity and my aesthetics as it does to physiology. No, when the cancer threatened my sexuality, my mind became immediately erect. I couldn't make up this stuff. I mean, he's a glorious writer, and he's reminding us, hey, everyone, I'm still me. In case you're wondering, I am still me. And then finally, the D of the ABCs of dignity-conserving care is about dialogue, conversations. And I would suggest to you that these are conversations that need to affirm personhood. The thing that if the psychology of illness is the psychology of loss, what all of us fear is losing ourselves, right? That somehow in the course of becoming ill, who we are and everything that we stand for will somehow vanish and disappear. And how frightening is that? It's the ultimate assault. So how do you study something like that? How do we put personhood on the clinical radar? Well, let me tell you about an interesting study that we just completed. And it's simple, and yet the results, I hope you'll agree, are really quite profound. We examined a question that I think is kind of the quintessential personhood question. What should I know about you as a person to help me take the best care of you that I can? It's about personhood. What do I need to know about you as a person? Now, why is that important? Because when somebody walks into your room when you're ill, no matter what that illness is, all of us want to be seen in a particular way. We don't want to be seen just as the patient. We want to be seen as Harvey Chochinov, as Brian Goldman, as the person that we are and we see ourselves to be. We can't change our illness necessarily, but can we change the lens that our healthcare provider looks through? And that's why I love this particular slide. Metaphorically, it says, asking the question, what do I need to know about you as a person to take the best care of you possible, might be that metaphorical lens. So we did a study in which we asked about 130 patients near the end of life, what do I need to know about you as a person to take the best care of you that we can? We listened carefully, we documented their answer, we wrote it down and summarized it into a paragraph or two at most. We came back to their bedside, we read it to them, we made sure, was it accurate? And finally, and here's the litmus test, would you want this on your chart? Now you would expect, if this is the lens they would want people to see them through, that everyone would want it on their chart. And I'll hold off on the results for just a moment. Let me tell you about what one individual patient, a First Nations woman said in response to her patient dignity question. Mrs. F says that because of the residential school, she'd always had a hard time trusting people. She, in fact, moved 82 times so as not to let anyone get too close to her. And while this has gotten better over time, she still struggles with being able to trust people. She wants to, but it is hard for her. She sometimes worries that people won't be told the whole truth, or that people will see her as not being deserving of the whole truth. She appreciates people being friendly towards her, but is frightened of authority figures. Authority scares me, but I'm not as bad as I used to be. This is the result of a conversation that took no more than 5 or 10 minutes. And when I read that, I think to myself, trying to look after this woman, trying to really understand who this person is, trying to attend to her comprehensive end-of-life care needs, as indeed she was end-of-life care. She had an advanced malignancy and was within the final weeks or months of life in a palliative care facility, trying to understand and meet her needs without knowing something as vital and as essentially, fundamentally a part of who she is, would seem to me like trying to walk from here to the end of this hallway blindfolded. It's possible. It wouldn't be pretty, and it wouldn't make a whole lot of sense. Now, when we conducted this study, here's the results, and again, ignore the small print. Oh, that is really a terrible slide, I have to say. I can't even read it myself from here. So what does it say? What it says is this: when we asked patients and families about whether or not this was valuable, all of them said it was accurate. 97% said, I want that information that you've just gathered on my chart. And in fact, nearly 80% said they wanted a copy to take with them. About 93% said, not only is this information important, but I think this information would be important for my healthcare provider to know, and nearly 80% said this is something that could influence the way they provide care. And similarly, when we asked healthcare providers about this information, they say in 90% of instances, they learned something new, something they did not previously know. And again, without going into all of the details, they said that this increased my sense of respect, it increased my empathy. Finding out who somebody was as a person changed my perception of them, that they are no longer simply a patient with a problem checklist that I have to attend to, but a whole person that I can understand and empathize with more. One other thing that I'll tell you about before ending my remarks, Brian mentioned that I have a book called Dignity Therapy. We discovered in the course of doing our work that it is of vital importance to people, especially people nearing end of life, to make sure that they still have something that makes it worthwhile for them to wake up in the morning, that they serve some purpose. And one of the things that all of us carry with us to the very end is the sense of love or affection or connection that we feel towards others. So what can we do if we're the patient to safeguard the well-being of people that we're going to leave behind? You know, we tend to think about patients and how we look after patients. The truth is, patients are people, and people have feelings, and those feelings oftentimes are feelings of affection for others. And so how can we enable them to express that affection, that concern, that care? So dignity therapy, without going into a lot of detail, really guides a person with a life-threatening or life-limiting illness through a conversation. And it's a conversation in which they can say the things that they would want said, they can share the wishes or dreams with loved ones that they would want to share advice, guidance, and so on. The conversation in this particular intervention is recorded, it's transcribed, edited, and then returned to the patient for them to give, to share, and to bequeath with a loved one. For example, if I think about the first gentleman that we enrolled in dignity therapy, he was a man with end-stage cancer. It was a colorectal cancer. He had given up on living. He said he had in fact gone on a hunger strike at home. His doctors were worried about him. They brought him into hospital. I was the psychiatrist. They were hoping that I might sprinkle things with Prozac and all of the problems would go away. Such was not the case. He was not clinically depressed, but he did tell me within the first minute or two of our being together that if he could press the button now in that European country, if we happened to be there, he would. And so I said to him afterwards, look, I mean, you're not suffering from any psychiatric illness. It sounds like life has been difficult. We have been developing this new approach that we call dignity therapy. It would give you a chance to record some of the important things that you might want said. And I described it to him, and he said that he would be very interested. So I arranged to come back with him on the following day. But before he left the room, I said, now, if you could press that button now, would you? And he sheepishly turned to me and said, well, no, I'd like to do this first. So I thought, oh my God, this is palliative care penicillin. It worked almost instantaneously. Came back the next day, however, we had a wonderful conversation about his family, about his immigration, about the tragic death of one of his children and the accomplishments of his other children that he was so proud of, and some of his worries and concerns and wishes for his aging wife and how he would want her to spend his time near the end of life. We recorded this, we transcribed it, and gave it back to him. He was too weak, actually, to take it from us, but his wife's words to us were, "This will be a blessing to our family." And this is a form of therapy that's now being done in a variety of palliative care programs and being studied in programs in various places around the world. I'm the only thing that stands between you and your snack and coffee at the intermission. So I am going to quickly finish off just to say I am also the chair of a project called the Canadian Virtual Hospice, virtualhospice.ca. This is a national resource. It is completely free. You can go online tonight, virtualhospice.ca. You will, if there's a question in palliative care that we haven't answered, I would be extremely surprised. And in fact, we have something called Ask a Professional. If there is a piece of information that you were looking for, and we've had so many questions come through Ask a Professional, if there's a piece of information you're looking for, if you give us the question within 48 hours or 2 working days, we will give you a response. And we've had questions that range everything from people in remote nursing stations who want help with managing difficult pain issues, to I remember a young woman who contacted us to say that her mother had just died, she'd never been to a funeral, and wanted to know what things were okay and not okay to say at a funeral. So I would encourage you to go online. It's a national resource and there for you to use. We have over 1,000 Canadians visiting every day, and the satisfaction from people who come to the Canadian Virtual Hospice is extraordinarily high. In closing, I'm hoping that this conversation tonight about end-of-life care demystifies some of the things that we've talked about. I hope it makes it easier for you to broach some of the conversations. Not talking about death doesn't mean that death will not come and find each and every one of us. And if we think back to that early video that I showed you, I mean, it seems to me that the moment we are born, our lives have taken flight. And we know that if our lives have taken flight, each and every one of us are destined to land one day. Good palliative care is about planning for good, safe landings with the least amount of suffering possible. That is, until our life comes to a complete and final stop. Thank you all very much.